Professor Elizabeth Teisberg and Scott Wallace, the directors of the Value Institute, which is part of both Dell Medical School and the McCombs School of Business at the University of Texas at Austin. Professor Teisberg holds the Cullen Trust for Higher Education Distinguished University Chair in Value-Based Care. She co-authored with Michael Porter the book Redefining Healthcare and is an expert on transformational innovation and the implementation of high-value healthcare. Professor Wallace is on the faculty at Dell Medical School and the McCombs School of Business. He was appointed by President George W. Bush to chair the Federal Commission on Systemic Interoperability, which advised the White House and Congress on information technology and health transformation.
Hi, so on behalf of the Value Institute team, welcome to our very first Value Institute webinar. So we wanted to think about things that have changed as a result of the pandemic, and we think three of them have really changed in a very significant way. So most of us have left our offices and we've moved online, but online doesn't apply just to work. It's how much of our social lives now occur. And it's really a very small step to go from talking to your family or your friends online to talking to your physician online.
A second sea change is unemployment. Tens of millions of people didn't just lose their jobs in the US, they lost their health insurance. Unemployment has eviscerated a huge swath of employer-sponsored health employer-sponsored health insurance system.
Third, relationships are changing. And because trusting relationships are critical to effective healthcare, this too may have sea change consequences in healthcare. So we're going to take a deeper look at the healthcare shifts due to these three sea changes. And we're going to look at the implications of those shifts for healthcare transformation. Let's start with the reality of living with distancing.
Crucial aspects of people's lives have moved online. Zoom has surpassed 300 million daily Zoom meeting participants. That's an amazing jump from the 10 million back in December. In healthcare, the related shift to online is due to people avoiding in-person care. Surveys show that more than a third of all Americans and half of American seniors are avoiding in-person care.
So telehealth is being tried by millions who now fear visiting a physician's office. 350,000 telehealth visits occurred in 2013, and the predictions now are for more than 1 billion this year, including many first-time users. Most people have been forced to adopt online and video communication, and that change has overcome a key hurdle for online care providers. People now know they can conduct all kinds of communication online. It works. Not perfectly and not for everything, but well enough to grow quickly.
Wow, that's how the seeds of disruption are sown. That transition to accepting a fundamentally different mode of care delivery that isn't perfect but works well enough for some purposes means that healthcare now faces a transition akin to bookstores, retail stores, and travel agents. We've jumped over the wall. Healthcare has gone virtual.
The second big change is as a result of unemployment. And the reality is that unemployment poses the biggest threat to the employer-sponsored health insurance model since that model was created during World War II. The Robert Wood Johnson Foundation is estimating that between 25 and 43 million people could lose their employer-sponsored health insurance in the pandemic. And these people face three choices, if you want to call them choices. Depending on the state in which they live, they might be able to enroll in Medicaid. They might be able to purchase coverage under the ACA. That depends on having the means and for it to be available in their state. Or they could become uninsured. In states like Texas that didn't expand Medicaid, about 40% of those individuals will become uninsured. The consulting firm Health Management Associates estimates that in Texas, almost 2 million people will lose employer-sponsored insurance. As a consequence, over 1 million more people will enroll in Medicaid, and 750,000 Texans will become uninsured.
Distancing clearly affects relationships, and this too will shift healthcare because effective care is predicated in trusting relationships. Interference with these relationships from overpacked schedules, EHRs, and insurance rules is at the root of clinician burnout. But the reality is that physicians have, for the most part, maintained relationships with patients. We love the doctors and nurses and physical therapists, the clinicians who care for us. The strength of those relationships for many people is the definition of good healthcare. Yet, for individuals and families who don't have a trusted caregiver or who can't reach that person now, this may be an inflection point.
So we see 4 important immediate implications of these shifts in healthcare. First, new healthcare competitors will effectively serve a lot more people.
Second, new care models will emerge because just like effective online education, effective healthcare has to be designed to be online.
Third, tens of millions of people will need care that is excellent and lower cost. The healthcare system just won't have the benefit of so many relatively well-paying employer-insured patients.
And fourth, relationships will be the asset that enables or prevents disruption of large established care providers.
New competitors will change the healthcare landscape really dramatically. As we've seen just in the past 2 months, having a big hospital that depends on in-person elective care might be a competitive disadvantage. Hospitals take up capital and management focus. They keep organizations wedded to the old ways of doing things. Increasingly, bricks and mortar providers will have to compete with platforms. So think Lyft versus a taxi, and think of the diabetes care platform Livongo versus a clinic. Platforms tend to grow exponentially, not linearly. So formerly niche players can grow very rapidly. In most platform-dominated industries, no one had heard of the big winners only a few years before they dominated their industry.
We've previously described telehealth as a genie that's out of the bottle and isn't going back in. Telehealth isn't a fad. For some types of care, the reality is that telehealth is here to stay. The logic of the move to online care is clear. As an oncologist recently remarked to us, "I don't know why I've had everyone coming in person." There's no real need for people to show up in a clinician's office for a lot of what happens in their care.
But the reality is providers do know why they've made people come in. That's how they make money. And that's not a slam on providers. Those rules are set by the government and by the health plans. But when people realize they've been inconvenienced and annoyed for no good reason, some of them are going to look for alternatives online. Think about online banking. 15 years ago, nobody thought online banking would work. But remember all those jokes about bankers' hours? The inconvenience of traditional banking pushed people to move online, and they did it really rapidly. Even before the pandemic, much of our lives was occurring online. And with the pandemic, the move online is happening to healthcare and to education.
Education illustrates the next huge implication. Effective online education requires design for the medium. The past 2 months have made clear to millions of students that effective online education is not simply a matter of putting current classes online. It's a different experience. Likewise, healthcare. New care models will emerge. Doing telehealth well isn't just a matter of looking at a patient through a camera. The promise of online care requires new models, new tools, new technologies. Care providers who design their services to be online will have a huge advantage over providers who simply flip open their computers and log on to Zoom.
At its core, online care requires building relationships in new ways. And very few providers have thought about or been trained in how to do this. From the really simple things like lighting and camera angles to really complicated ones like how to do a physical exam on someone who isn't in the room, providers are going to have new tools for building and maintaining the crucial relationships they need with their patients. Obviously, online also gives a whole new structure for how appointments are scheduled and managed. And again, the takeaway is that those who are designing for this have an advantage over those who are defaulted into it. Finally, online offers a huge array of new options for how the care team is constructed and how the roles are assigned. From medical assistants to coaches to nurses to physicians and to all the other caregivers, particularly psychologists and social workers and psychiatrists, the opportunities for a new kind of team-based care are dramatically different online.
So let's take a minute to ask about your telehealth experience from the patient's perspective, as a patient. So let's try this poll, and you can click as many of the things as are relevant for you. So this isn't a vote once, this is a click the ones that...
This is a Chicago poll. You can vote as many times as you want.
So Scott can see the
yeah, the leading is people have tried it for convenience. And only 2% of the respondents have never been a patient in a...
Wow.
All right, Casey, you want to put that up? So now you can see that 52% of the people who responded use it for convenience, 34% only if it's paid for by their insurance, and 18% mention that it's dependent on already having a relationship with the clinician.
New care models and teams with new roles are key to the next point we want to make. Providers are going to have to find ways to make care dramatically more affordable. With so many people not covered by employer-sponsored health plans, providers will need to serve people whom they've not typically served in the past and who can no longer pay as much.
Providers will emerge with the capacity to serve those who can't afford conventional, hospital-based, physician-centric care. In reality, they already do. Think of all of the nurse practitioner-staffed clinics that treat routine conditions like sinus infections and pink eye. Those services will proliferate way beyond the corner Walgreens or CVS. In parallel with these new models of care, there will have to be new models of payment. Walmart has launched primary care, and it will accept insurance, but it's designed to be affordable for people to pay out of pocket. Not just out of pocket for copays and deductibles, but out of pocket for all of their care. So we think about big healthcare organizations today, and they're established and protected, kind of like the walled cities of the past. But outsiders, new services, are breaching the parapet. As we've discussed, the lock on trusted relationships has been breached by the pandemic. For starters, huge portions of the population now realize that telehealth works. good care is only a few clicks away.
Facilities seen as part and parcel of loyalty and the relationship to a care system are disruptible. The past couple of months have shown just how big a liability a hospital building with its expensive resources can be. But even more importantly, brands can be disrupted. Brands matter, clearly, but they're strongest when they're based on strategy, on distinctive activities and offerings. If new entrants establish trusted relationships in the convenience of online care, then existing brand name providers have to compete anew to get patients. And the competition is internet-wide.
So enormous changes may disrupt significant parts of the healthcare system. And leaders can wait and predict and react, or they can be really proactive and shape the future.